Hello, this is Dr. Patrick Fernandez. I'm a pediatric anesthesiologist at Children's Hospital Colorado and the University of Colorado School of Medicine. Over the next 10 minutes, I will summarize the educational review article entitled Perioperative Considerations for the Food Allergic Pediatric Patient for the journal Pediatric Anesthesia. This article was a collaboration between myself and Dr. Marco Mikhail, a pediatric anesthesiologist in the Department of Anesthesia and Pain Management at Cook County Hospital in Chicago. I will begin with a brief summary of key learning points, followed by a discussion of important reflective questions. Let's begin with a classification of adverse food reactions. These reactions are quite broad and can be classified as immune-mediated, non-immune-mediated, and toxic reactions. Immune-mediated reactions can be further divided into food allergy and celiac disease. Food allergy, the focus of our educational review, can be further subdivided into IgE-mediated, non-IgE-mediated, and mixed-type reactions. IgE-mediated food allergies are classic and common food allergies. Non-IgE-mediated allergies are less common and include entities such as food protein-induced enterocolitis syndrome, also known as FPIES. Mixed-type allergies include diagnoses such as cow's milk protein allergy and eosinophilic esophagitis. With a good classification structure in mind, I will now discuss the pathophysiologic mechanisms of IgE and non-IgE-mediated food allergy. Allergy and immunology literature defines a complete allergen as a substance capable of inducing sensitization and triggering a clinical reaction. With respect to food allergy, small, water-soluble, heat, and acid-resistant glycoproteins are typically the complete allergens. IgE-mediated food allergy is the result of abnormal sensitization leading to development of antibodies to harmless food proteins, setting the stage for type 1 hypersensitivity to occur. Type 1 hypersensitivity reactions result in the release of chemical mediators culminating in physiologic consequences and clinical symptoms. Clinical symptoms can manifest in various organ systems, including the skin, respiratory tract, cardiovascular system, and the GI tract. While IgE-mediated food allergy can lead to immediate and severe symptoms, as is the nature of a type 1 hypersensitivity reaction, non-IgE-mediated food allergies tend to result in delayed symptoms that primarily manifest in the GI tract. The precise pathophysiologic mechanism for this delayed response is poorly understood, but is thought to represent a defect in the protective and immunologic function of the GI tract. It is thought that ingestion of the culprit food leads to activation of T cells and release of pro-inflammatory mediators such as TNF-alpha, leading to intestinal inflammation. With basic understanding of the pathophysiologic mechanisms behind food allergy in mind, I will now turn to a discussion of some perioperative considerations in children with food allergy. Preoperative factors impacting both the patient and the anesthesia provider should be considered when caring for these patients. With respect to the patient, atopic children may be at greater risk for developing adverse respiratory reactions under anesthesia because of increased risk of laryngospasm, bronchospasm, breath holding, and desaturations. A discussion about a patient's allergy history should not be limited to medication allergies alone, as certain aspects of food allergy are potentially relevant. From the perspective of the anesthesia provider, we should consider our own potential exposure to food allergens throughout the day, for example during a lunch break, as this could impact highly sensitive patients. Peanut and tree nut allergies are some of the most severe and life-threatening, accounting for greater than 90% of fatalities due to anaphylactic reactions to food. Type of exposure, minimum dose of allergen exposure, and effective means of allergen decontamination are all relevant to pediatric anesthesiologists caring for these highly sensitive nut allergic patients. Fortunately, it has been shown that common peanut allergens are easily cleaned from hands using soap and water and from tabletops using common household cleaners. Therefore, as we care for patients throughout the day, the simple act of washing hands with soap and water after eating will likely be effective at reducing incidental exposure to our patients. Another preoperative question is what type of food allergy reaction might warrant cancellation of an elective procedure. Obviously, it is sensible to delay an elective surgery in the setting of a severe food allergy resulting in life-threatening symptoms such as hypotension or bronchospasm. However, in the setting of more mild reactions, such as urticaria, the clinical decision is far less obvious. Given that there is limited data, extrapolating from the immunization literature might give us some basic recommendations. With respect to immunizations, a recent urticarial reaction due to an immunization could be misinterpreted as a preoperative hypersensitivity reaction. This concern has led some to recommend postponement of elective procedures for up to 3 weeks after receiving a live attenuated vaccination. With this in mind, similarly, it may be practical to postpone an elective surgery in the setting of a recent mild food allergy if there is concern that the preoperative presence of such symptoms might be confused with an allergic reaction secondary to perioperative medications. The primary intraoperative concern with respect to food allergy stems from the potential for cross-reactivity between food allergy and certain medications or substances that a patient may be exposed to. With this in mind, only iodinated media, Protamine, Latex, and Propofol are pertinent to this discussion. We will begin with iodinated substances. Substances such as iodine surgical skin preparation or radiocontrast media and Protamine have been linked to theoretical concerns for cross-reactivity with fish or seafood allergy. There is no evidence in the literature linking seafood allergy to iodinated agents. Unfortunately, the story for Protamine is less straightforward. Protamine is a low molecular weight protein that is commercially derived from salmon milts or sperm. Because Protamine is a protein, it could theoretically result in IgE-mediated hypersensitivity due to cross-reactivity in someone with a fish allergy. As fish allergies tend to develop in adulthood, this is less likely to be a concern for pediatric anesthesiologists. However, if there is concern, a patient should be allergy tested for both fish and Protamine, and an alternative to Protamine may be in order. I will now briefly discuss the latex fruit syndrome. The potential for severe reactions has led to the implementation of latex-free strategies that are nearly ubiquitous in modern healthcare settings. While such latex-free strategies have decreased risk, cross-reactivity between latex and certain fruits, also known as the latex fruit syndrome, is relevant to our discussion. As detailed in our review, it is prudent to consider latex precautions for children with hypersensitivity to banana, avocado, kiwi, and chestnut, as these are the most frequently implicated foods in the latex fruit syndrome. I will conclude my discussion about intraoperative considerations with Propofol. It is well known that the concern with Propofol stems from its egg and soy contents. The first important point is that, as stated earlier, proteins are the complete allergens in food allergy, and this fact is the same for egg and soy. Lecithin, a highly purified egg phosphatide, and highly refined soy oil are the food components found in Propofol, neither of which are proteins. An evaluation of the literature reveals that any concerns with food allergy and Propofol are unsubstantiated. While our contention is that cross-reaction between food allergy and perioperative substances is highly unlikely, a discussion of post-operative allergy management is important. In the event of any perioperative hypersensitivity reaction, thorough evaluation is key and ideally involves collaboration between the anesthesiologist of record and an allergist. In an effort to provide an accurate history, any suspected perioperative allergic reaction should be well documented in the anesthetic record, with attention to symptoms and their timing relative to medication administration. It is prudent to await the results of an allergist workup before a new substance is added to a patient's allergy list in their medical record, in order to ensure the allergy record is as accurate as possible. With this summary of our review as a foundation, I will now briefly discuss our reflective questions. Question 1. What components of foods are most likely to result in IgE-mediated hypersensitivity? Small, water-soluble, heat and acid-resistant glycoproteins are most likely to result in hypersensitivity to food. Further, food components such as carbohydrates and additives are rarely culprits with respect to inducing an IgE reaction. Question 2. Why are iodinated medications not a concern in patients with allergy to fish or seafood? The myth of iodine allergy has its roots in case reports from the 1970s, in which patients reacted to contrast media. Some of these patients had food allergy, but they also had other allergies as well. This wrongly became perpetuated as a, quote, allergy to iodine. The key issue is that protein components in fish, most commonly tropomyosin, are the cause of allergy and not iodine. Question 3. How might you alter your anesthetic plan for a patient with either IgE-mediated or non-IgE-mediated allergy to egg or soy after reading this review? I would not alter my anesthetic plan for any patient with an egg or soy allergy. Knowing that the pathophysiology of IgE-mediated food allergy is triggered by protein components of egg and soy, and that Propofol does not contain any protein components, I am confident that patients can safely receive this medication. This is substantiated by the preponderance of the evidence in the literature to date. And finally, question 4. What is an important component of post-operative management following a suspected and resolved perioperative hypersensitivity reaction? A key component is evaluation by an allergist to determine what, if any, perioperative medication triggered a reaction. Information gained from this expert evaluation should then be used to accurately update a patient's allergy record. With that, I will wrap up our discussion. I have only provided a brief summary of key perioperative considerations when thinking about food allergy in our pediatric anesthetic patients. For the complete story, I encourage everyone to read the entire review, which can be found in the journal Pediatric Anesthesia. Thank you.